palliative care. And now we are moving on to another important topic, pain. So we know that pain is a common symptom, not only in cancer patients, but also in many other patients, or even many of us who are going to or attending the today's session may have pain. So it's a common symptom everybody has. Vineetha will be um, talking to us regarding the basics of pain. So Vineetha is an anesthetist who has MD in anesthesia from Kerala, and followed by that she did her fellowship in pain medicine from Sanjay Gandhi Postgraduate Institute, Lucknow, and she has also done in fellowship in intervention pain management from Daradia, Kolkata, and she has also done 6-week certificate course in pain and palliative medicine, and she has worked in palliative care for about 2 years with us. She is now working as consultant in pain medicine in KIMS Hospital, Trivandrum, and she is also a visiting consultant in our institute. She has a particular interest in interventional pain management, regenerative medicines, cancer pain and palliative care, and neuropathic pain. Even though she is working in a hospital, but we talk to each other for managing patients. So thank you, Vineetha, for being with us, and it's over to you.
Thank you, sir, for the kind words. I hope I'm audible and visible and clear.
Yes, yes.
Shall I share my PPT? Just a minute. Is my screen visible, sir?
No.
Not yet.
Not yet. Is it visible now, sir?
Yes, yes. Vineetha, yeah. No.
Yes, sir, please tell.
It's visible.
Okay, I hope I'm visible, sir.
Yes, yes.
Okay. So, good evening, everyone. As Sunil sir has introduced, I'm Dr. Vineetha. I'm a consultant in pain medicine. So, I work with a corporate hospital in Trivandrum, but I'm also a member of the Pallium India family. I'm visiting consultant for TIPS Pallium India. So, today, my topic for today is introduction to pain. So, this is a very, very basic topic, and I will try to keep it very simple and basic, because in the following classes you will learn about more about pain, the management, and how to deal with complex pain and everything. So this is very much a simple section. And one thing is, I have actually prepared this in a another computer, and now I am presenting in my iPad. So some animations are not going to work properly, so I ask your forgiveness for that beforehand. So with that, we go on to our class. So I'll be dealing the session in these 4 headings. The first will deal with the definition and the epidemiology of pain, like the incidence, prevalence, and all. Then the classification. then the physiology, pathophysiology, and the assessment of pain. And I would like to the class to be interactive. So in between, if I ask any questions, please feel free to discuss, because otherwise so much of theory means we will all start sleeping after some point of time. So I'll first start with this story, which this patient came to my OPD around 1 month back. So a 36-year-old male patient who complained of pain that starts in this is not a cancer patient, this is a chronic pain patient, pain that starts in the suboccipital region and radiates to the head for the last 21 years. So he was diagnosed with migraine at the age of 15 years. And since then, he has been taking treatment from multiple neurologists and multiple other physicians from India as well as from abroad. And for the past 4 to 5 years, he has got severe intermittent headache of the intensity of 10 by 10. His mood is affected, sleep affected, work affected. And now he has got multiple aches and pains. He has upper back pain, neck pain, leg pain, and everything. So when such a patient with a difficult pain, a complex pain everywhere that comes to me, I often ask two things. One is that where does the pain start and where it hurts most? So for this patient also, I asked, okay, what is that hurts you the most now? But I was expecting the patient to say headache is the worst or the arm pain is the worst. But actually his answer surprised me. Not that it surprised, it is something which I constantly hear from chronic pain patients. But my question was entirely different. What hurts you the most? And he replied that what hurts me most is that nobody understands my pain. And this is exactly the words that he used. So in chronic pain, maybe in cancer pain or non-cancer pain, chronic pain is like a invisible illness. Nobody understands it. Nobody sees that. Nobody adequately assesses the severity of the pain, and the patients are often led to suffer for alone. So in this class, this basic introductory class, my most important aim is not to teach the complex pain pathways or how it works, but most importantly, some basic things that we should know when we are dealing with a chronic pain patient, how it is different from acute pain. So some of you might be already trained in pain and palliative medicine, but some of me, I presume that most of you are very new to the subject. So there are certain things which we often miss or mistake in our initial days. So those things I'm going to emphasize in this class. So what is the definition of pain? So the International Association for the Study of Pain, IASP, in 2020, it coined the newer definition, that is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. But in simple words, pain is what the patient says hurts. That means the lesson number 1 here is we should believe when the patient says it hurts. Believe your patient. And I will be telling that constantly, n number of times throughout this presentation, because I am a person who keeps hearing every day from my colleagues, from my other clinicians that, oh, this is functional. If they cannot pinpoint that this particular structure as the pain generator, if they cannot pinpoint the one particular reason as the etiology, then often the pain is labeled as functional. In cancer pain, the pain is often labeled as completely psychological, or this patient just came to know about his diagnosis. So the pain physical component is very less. The patient is mostly having psychological pain, so we can't do anything. So I keep hearing this from many of my colleagues. So throughout my presentation, I will be telling this repeatedly that the first and the most important point is believe your patient. And especially when it comes to chronic pain, you should know the definition of pain as well as you should know the definition or the concept of total pain. So anybody here has got any idea what total pain is about?
It is about physical, social, psychological, and
Spiritual.
Spiritual. Yes, very good. So basically, total pain means if you are looking only at the physical component of pain, this is a scenario. You are just dealing with the tip of the iceberg. So when you look at the patient's total pain experience, it has got physical component, psychological component, spiritual component, and a social component. These 4 domains also you have to take into account. So physical, we know, caused by the cancer, caused by the treatment, or caused by the comorbidities. What are the psychological problems these patients usually have? Anxiety, depression, fear of suffering, fear of death. And the spiritual problems, why this happened to me? Is it due to my mistakes I did in my past life or the present life? So the loss of faith, the questions like this, questioning the religion. So all this comes under the spiritual concerns. And social concerns means he might be the patient might have been the sole breadwinner of the family, but now he has lost his job, he has lost his role in the family, he has a lot of debt, financial concerns, and so all these comes under the socioeconomic or the social concerns. So all these factors, all these 4 domains equally contribute to the patient's total pain experience. And when we deal with such patients, our aim is not to just provide the pain relief. Our aim is to improve the quality of life. So if you have to improve the quality of life, if you have to improve the functionality, you have to look at all these 4 domains and you have to understand the concept of total pain. Now, a little bit about the incidence of moderate or severe pain in cancer. So this study published in 2016. So it found out that in any stage, if you take together all the stages, around 50 to 70%, 50% is the occurrence of moderate to severe pain. It is not about the mild pain. The occurrence of moderate to severe pain, taken all the stages of cancer together, is around 50%. And when you go at, when you look at the advanced stages, it is about 70%. 70% patients will have moderate to severe pain. And the same study showed the prevalence. Here also you can see that in advanced or metastatic cancer, almost 66% is the prevalence of moderate to severe pain. Now, the question is, are we treating pain adequately? So this is a very good study. You can go back, Google it and read the entire study. It is very interesting to read. So this study in 2018, it found out that what is the adequacy of pain relief? In mild pain, we were able to provide adequate pain relief in 50% patients. In moderate pain, we were able to provide adequate pain relief only in less than 20% of patients. And in severe pain, 95% of patients did not get adequate pain relief. And in this study, they have told that it is due to 2 reasons. One, the patient-related reasons, and the hospital or the clinician-related reasons. The patient-related reason they found mainly was financial concerns. Due to financial concerns, they couldn't buy the medicine or they couldn't go to the hospital. And all the other was the physician-related concern because we did not assess or manage the pain properly. So with this introduction, and one more thing is there. So I basically now deal with a lot of non-cancer chronic pain patients and I do interventions for them. So unfortunately, the scenario is even worse with non-cancer chronic pain. So this study found that almost 20% at any point of time, at least 20% Indian adults, they suffer from some kind of chronic pain. So, you know, what is different? There are so many things different from cancer pain, but one very important thing is when a cancer patient come to you, they have a diagnosis, okay, CA pancreas or CA breast with bone mets. So you know why the patient is suffering, why the patient is having pain. The diagnosis is obvious. But when a patient comes with backache to you and you have found that MRI is normal, all the blood investigations are normal. So our colleagues, most of the, I won't tell everyone, but many of the clinicians, what they do is when they are unable to reach a diagnosis, they label it as functional or malingering. But thing is that chronic pain, be it backache, headache, or any musculoskeletal pain, or it can occur without any abnormality in any of the investigations. Okay, so these patients are, they do a lot of doctor hopping and hospital hopping and doctor shopping. They go to psychiatrists, they go to everywhere without getting a proper treatment. So, and we cannot prescribe opioids also these patients. So these patients also suffer like very much similar to cancer pain, and their quality of life is often very severely affected. So the story here is that chronic pain is one of the most underestimated and undertreated healthcare problems in world today. If you take any hospital, almost 50 to 70% of patients coming to there have their presenting complaint as pain, but still it is one of the most underestimated and undertreated healthcare problems in our society. So with that, we go to the classification of pain. So I hope you are clear with the basic concepts regarding the definition of pain, and that you have to believe your patient. So the classification of pain, the first classification or the temporal classification, sorry, just a minute. Okay, the temporal classification is based on the time. It is divided into acute pain and chronic pain. So any pain with duration less than 3 months is acute, and more than 3 months is classified as chronic. Then, depending on the nature of the pain, another classification is into nociceptive pain, neuropathic pain, and nociplastic pain. So nociceptive pain is when the tissue nociceptors are injured. Neuropathic pain occurs when the nervous system itself is either injured or is not functioning properly. Now, anybody here knows what is nociplastic pain? This is a relatively newer concept. The IASP has, International Association for the Study of Pain, has coined this term recently. So anybody here is aware of this nociplastic pain? So if you don't know, nociplastic pain is nociceptive pain. The tissue nociceptors are damaged, are injured. Neuropathic pain, the nervous system is not functioning properly. When there is no such injury, either to the nociceptor, nor to the nervous system, but the patient is having an altered nociception, then that kind of pain is known as nociplastic pain. So can anybody tell me an example of nociplastic pain? That is, there is no injury to the nociceptor. There is no injury to the nervous system. There is no dysfunction of the nervous system, but the patient is having pain everywhere, or altered nociception. So simple example is
persistent post-surgical pain.
yes, persistent post-surgical pain. It's okay. And another example,
Phantom
very,
limb.
pardon?
Vineetha, there are some
Somebody
thoughts
is
in the chat
unmuted.
box.
Okay, chat box,
Central
sorry.
sensitization,
Okay.
allodynia, fibromyalgia, phantom limb, generalized
That was the
myalgia.
word. That was the word I was looking for. The classical example of nociplastic pain is fibromyalgia. Okay. But there are, of course, there are many other like post-surgical pain also. Sometimes it can occur without any cause. Some post-surgical pains are neuropathic pains due to the nerve injury that has happened during the surgery. But some post-surgical pains, post-thoracotomy, post-mastectomy, sometimes they have pain without any obvious injury to the nociceptors or the neuropathic nervous system. But the classical example for nociplastic pain is fibromyalgia. Okay. Then, so coming to the acute versus chronic pain, this is very important, especially for the beginners. Because even in my pain management team, I have a pain management team in my hospital with doctors, nurses, and physiotherapists, psychotherapists. Even in that pain management team, when I joined, I have found that a patient in chronic pain and a patient in acute pain, a patient with chronic pain, their pain behavior is slightly different. Okay, I will tell you with the next example. So you can see the difference here. A 54-year-old gentleman, a metastatic lung carcinoma. So he comes with a pathological fracture of right humerus. It is a fracture and acute pain. The patient is wincing and grimacing in pain, has tachycardia, sweating, and he says that he is in severe pain. Everyone in the ER believes him. And there is no confusion. Now, a 60-year-old gentleman with carcinoma head of the pancreas on chemotherapy for the past 4 months, he says that he's in severe pain. He does not appear to be in distress. He looks tired, gloomy, and has decreased appetite and sleep. So will you believe the patient? So this I have found that even in my pain management team, the teammates telling this, the patient looks okay. When I go and ask the patient what is the pain score, he says 10 out of 10. But just as I leave the room, I have seen him talking to his daughter in the mobile. He looks okay for me, madam. But this is because they don't know the pathophysiology or they don't know what happens in the chronic pain. So chronic pain patients may not appear to be in distress. So chronic pain will have an ill-defined onset and a prolonged fluctuating course. And this fluctuating course is also another important thing. So recently, I have seen one patient referred to me from some other center, a cancer pain patient. So this patient has already been seen by a pain physician only at some other center. And I saw that the patient, the drug given to the patient was Ultracet Semi. I don't know how many of you know about Ultracet Semi. It is half the dose of Ultracet. That is tramadol 37.5 is there in Ultracet, and Ultracet Semi means it is tramadol 17.25 and paracetamol 175 something. So this patient is a normally built and nourished person with so much of pain, and I was concerned why this patient was given Ultracet Semi despite he is in such severe pain. So I talked to that particular clinician, and what that person told me is yesterday when that patient was sitting in front of me, I asked the pain score. The patient told me 3 to 4 out of 10. So this is what we have to understand here. It has got a fluctuating course. So if you just ask the pain score at the moment and the medicines accordingly, you're going to land up in trouble. No, you're actually going to make the patient suffer. You have to always ask how much was your worst pain, how much was the average pain in the last 24 hours. So when we come to the pain assessment, I'll come to that in detail. So before you prescribe the drug, don't just take into account the present pain. Always at least ask pain in the last 24 hours. Okay. And the overt pain behaviors like grimacing, sympathetic hyperactivity will be typically absent in chronic pain. Vegetative signs like lack of interest, lack of sleep, lack of appetite, those things will be present. And the patient may not appear to be in pain or distress at times. And the only definitive way to determine the presence of pain is to obtain a verbal report from the patient. So again and again, as I say, you have to believe the patient. So believe your patient, treat early and treat them well. Okay. So this is what I told. The animations have come a slightly different in this iPad. So the nociceptive versus neuropathic pain. So the first classification was acute versus chronic. Now nociceptive versus neuropathic. So this is very, very important. I'll tell you why. So nociceptive means there is a tissue injury and the nociceptors got damaged. So here it can be either somatic or visceral. Then neuropathic means there is either a nerve injury or dysfunction. So why do you want to differentiate between these two, nociceptive or neuropathic pain? What is the character of nociceptive pain? The character of Nociceptive pain is like throbbing, dull aching, catching kind of pain. Whereas neuropathic pain, when the nervous system itself is injured or dysfunctioning, you will have burning, shooting, scalding type of pain, numbness, tinkling, pin pricking sensation. These are the kind of symptoms. So this is something very important, that when you assess, when you take the history, you should know whether the patient is having predominantly a nociceptive pain or a neuropathic pain, because nociceptive pain responds to the traditional analgesics like NSAIDs, opioids very well, whereas neuropathic pain, it will not respond to the traditional, our conventional analgesics. For that, you need to give the anti-neuropathic agents. So here also, in the institution where I am working, I had a patient with diabetic neuropathy. He was in very severe pain, 10 out of 10, and he was admitted on an evening. So the next day, so I actually was not available that day. And in our hospital, the protocol is that whenever the patient is having severe pain, we start on fentanyl PCA, patient-controlled analgesia. So this patient, along with paracetamol and all, they started this fentanyl patient-controlled analgesia. The next day when I went there, the sisters, the nurses told me, ma'am, the patient is having some psychological issue. So we are giving him fentanyl, the strongest opioid in the hospital, but still the patient is telling 10 out of 10 pain. So even not just a staff nurse, the postgraduate resident belonging to another department was also telling me, I think the patient is having some functional problem, malingering. Again, why? Because they don't know this part of the physiology. That is, if it is neuropathic pain, even if you give 100 microgram fentanyl, sometimes it is not going to work. There may be a partial, some response, it is not going to work well. For neuropathic pain, we had to give neuropathic agents, and I think in the management class, they will discuss some opioids, not fentanyl, but some opioids. Just to wake you up, I'll ask this question. Can you tell me some opioids with action on neuropathic pain? Those who have already got some training in pain can answer this question. Just to wake you up.
Methadone?
Yeah, very good, Methadone. Again, there are two more.
Tramadol, madam.
Tramadol, very good. One more. One more is there. I'll give you a clue. Patch. Transdermal patch.
Buprenorphine.
Very good. Buprenorphine. Yes, yes.
Buprenorphine.
I am using buprenorphine with very good efficacy for neuropathic pain conditions like diabetic neuropathy, as well as some limb ischemia also. Because even though the pathology is ischemia, there will be neural ischemia and there will be neuropathic kind of pain. The only problem is buprenorphine patch is very expensive, and 900 to 1,200 rupees for 7 days. But these three opioids have got some role in neuropathic pain. Morphine, fentanyl, not going to have much benefit in neuropathic pain. Okay. So I'm happy to get answers from you. Now, so with that, we go on to the next section after the classification. Any doubts so far you can ask, otherwise what we'll discuss at the end of the class. So the next section is about the physiology and pathophysiology. You know why it is important to learn physiology? Do you know this story? Everybody knows this. If you don't know the physiology and pathophysiology and you are treating a pain patient, it is like this. Each one of you will perceive it as something else. One will perceive it as a nociceptive pain, one will perceive it as a neuropathic pain, one will perceive the patient is functional, one will perceive the patient is malingering. So unless you know what happens at the spinal cord level or what happens in the periphery and how the whole thing of this pain pathway works, I am not going to detail. One full 1 hour I can talk about pain physiology, but there is only one word that I am going to stress in physiology and pathophysiology, that I will talk about that. Okay, only one word. So this pain pathway, in the most the simple terms, it starts in the periphery, the peripheral nerve. A, delta, and C, these are the nerve fibers that carry pain, and their free nerve endings act as the nociceptors. So whenever there is a tissue injury or a tissue pathology, these free nerve endings, they get activated and the signal is transmitted via this nerve to the dorsal horn. Okay, dorsal horn of the spinal cord, and from there to the brain. Now, the question is, if the stimulus remained constant, whatever is causing the pain, what a tissue injury, let us assume, for example, acute pain. You have injured your hand and a small injury, a cut injury. Now you are in severe pain. What happens with time? Usually, it's a small injury that heals on itself. What happens with time? The pain will decrease, increase, or remain constant. The second scenario, yeah, what is the answer?
Decreases.
Yeah, it decreases. Acute pain, it is like that. What about in chronic pain? With time, usually what happens, especially if you are not managing properly, what will happen?
It will increase.
It will increase over time. Okay, so we will learn from pathophysiology how that happens. So this the first figure, I don't know how to take the pointer in this. Okay, very sorry. In the first figure, that marked in blue is the spinothalamic tract that everyone knows, I think. The spinothalamic tract is a lateral pain pathway that carries pain, the major pathway that carries pain. But what is important to remember, you look at the second picture on the right side of the screen, the one marked in red is a spinothalamic tract, but this is not just the ascending tract. We have another ascending tract or tracts near the red one, the one marked in green, which includes the spinoreticular and the spinolimbic pathways. Again, the pathway marked in blue, that is the descending pathway. Okay, from the brainstem and from the medulla, from the midbrain and brainstem to the spinal cord. So, if the function of this red pathway, that is spinothalamic tract, is the perception of pain, that is a major pain pathway. What is the function of this green pathway, the spinoreticular, spinolimbic? Anyone?
The emotional aspect of the pain.
Yes, very good. Emotional aspect, autonomic responses. All these are, and one more important word, which I am going to discuss in the next. Pardon? Yeah. Sensitization. Correct. So the emotional, autonomic responses, and the most important word, I told you, only one word you have to remember in the pain pathway and pathophysiology, that is sensitization. All these three, emotional responses, autonomic responses, and sensitization. These three are done by this green, spinoreticular, spinolimbic pathway, along with the help of descending pathways, which you see in the green color. Sorry, blue color. The descending pathways. Okay. So this ascending, that spinolimbic and spinoreticular pathways and the descending pathway, as I told, that is important for the modulation of pain. So the modulation of pain, there are two types of modulation. One is the modulation in such a way that if we are not managing our patient's pain properly, so much of time has already passed, and we have been underestimating the severity. We have been labeling it as functional, or we have been labeling it as mostly a psychological pain. As time passes, what happens is the patient will come to you telling that even touch hurts me. What happens in fibromyalgia and everything. So that is known as the excitatory modulation or sensitization, the most important word in pain pathophysiology. Then, suppose we are treating the patient well. As I said earlier, treat early and treat well. And also due to the natural course of the disease, suppose a patient comes and tells with time the pain has become much better now, that is the inhibitory modulation. So I won't be talking about inhibitory modulation here because that is something nice. We will talk about excitatory modulation or sensitization. Okay. So in the most simple words, what is sensitization is that basically there are two types of sensitization, peripheral and central. So what happens in the periphery? So you can compare the red markings and the black markings in the periphery. So what happens in the periphery when a tissue injury occurs? What happens is that some of the inflammatory cells will be recruited. These inflammatory cells will secrete substances like substance P, then substance P, bradykinin, and this is known as inflammatory soup. This inflammatory soup will cause more activation of the peripheral nociceptors. The sleeping nociceptors will be, woken up. That is what is happening in the periphery. So for any particular given stimuli, now the response of the peripheral nerve will be more. The input is the same, but the peripheral nerve will be now more sensitive. More number of peripheral nociceptors will get activated. Now what happens in that is peripheral sensitization. And the result of peripheral sensitization is primary hyperalgesia. That is, even if you are just pressing on that area, the area which is injured, you are just giving a subnoxious stimuli. You are giving a noxious stimuli, but there will be an exaggerated response. That is known as primary hyperalgesia, and this is due to the peripheral sensitization. For any given stimuli, there is an exaggerated response from the peripheral nerve ending, and that is known as peripheral sensitization, and that causes primary hyperalgesia. Now, what happens in the dorsal horn? What happens in the dorsal horn is when the input of signals, when the incoming signals from the peripheral nerve increases, some changes happen in the dorsal horn. You might have heard about NMDA receptors and all those things. So some changes happen in the dorsal horn, and ultimately what happens is known as the wind-up phenomenon or neuroplasticity. There is some kind of synaptic reorganization occurs in the dorsal horn, and now two things happen. You don't have to remember all these words, but two things happen. Number one is increased excitability of the dorsal horn neuron. That is, earlier 5x was coming. Suppose 5x was the pain coming from periphery, the dorsal horn will send 5x to the brain. But now there is increased excitability of the dorsal horn neuron. 5x coming from periphery, dorsal horn will project that as 10x to the brain. The second change is increase in the receptive field of the pain. Suppose you are increasing the receptive field of the dorsal horn neuron. Suppose your pain was originally coming from the C6 dermatome. Okay, the dorsal horn will tell the brain that the pain is coming from the C6 dermatome. But now, after sensitization, what happens is you give a slightly painful stimuli to the C7 dermatome. Then also that will be perceived as a pain by the dorsal horn to the brain. This causes what is known as secondary hyperalgesia and allodynia. So one is increase in the excitability of the dorsal horn neuron. Second is increase in the receptive field of the dorsal horn neuron. So that is why when you press the C6 dermatome earlier, just you give a slightly painful stimuli, patient is having an exaggerated response. Now you give the same stimuli to C7 dermatome or C8 dermatome. Now also the patient is having an exaggerated response, which is known as secondary hyperalgesia. And what is allodynia? What is allodynia? Anybody here knows what is allodynia? Again, just to wake you up.
A non-painful stimulus is perceived as a painful stimulus.
Yes, very good. The pain, the touch, even touch is perceived as pain. So this is due to the synaptic reorganization in which the A beta neurons, which carry the touch, is also now synapsing in the lamina 1 and 2 of spinal cord, where this A delta and C fibers, mainly C fibers, synapse. So due to the synaptic reorganization and some, sprouting and all, so much of physiology is there, but the net occurrence is that even touch becomes painful. So you should remember that primary hyperalgesia, secondary hyperalgesia, allodynia, all these are due to sensitization, peripheral and central sensitization. So if you don't know this physiology, a patient comes to you, pathophysiology rather, a patient comes to you in ER with severe pain, you are examining the patient, you are touching the abdomen, the patient screams in pain, you will tell to the staff nurse, see, I have just touched the patient and she is screaming. There is something wrong with her, higher levels. Again, the patient is malingering, the patient is, having some psychological issues. That is because we don't know the pathophysiology. Allodynia is commonly seen in neuropathic pain conditions, in any condition with central sensitization like fibromyalgia, or even in cancer patients when there is a lot of central and peripheral sensitization, we see even touch becomes painful. So after this class, even if you forget everything else, don't forget the importance of sensitization, because as pain physicians, our role as pain and palliative care physicians, our role or our aim should be to intervene early before the sensitization sets in, or if it has already set in, then please recognize and target it accordingly. Okay, that should be our role. So that ends the physiology and pathophysiology of pain. So I have kept it as simple as possible, but even then, if you have not understood anything regarding sensitization, you can ask towards the end of the class. And from that, and with that, we move to the last session in short, that is an assessment of pain. So that is mainly the history taking. I'm not going to talk about the examination or anything here, just a few salient points about the history taking. So when you take history of a cancer pain or any chronic pain patient, we should have some aims, right? Our target. So our aim should be to identify the nature of pain, the character, with neuropathic pain, nociceptive pain, the severity, the associated factors, the associated factors, temporal association, and all those things. Okay. Secondly, we will try to identify the etiology and pathophysiology. This is very important. For example, I have heard this story from Rajagopal sir only, I think many years back when I was attending the CCPPM course, because a patient who was being treated for CA pancreas, I think, an abdominal malignancy in a corporate setup in our part of the state. This patient came to Pallium India with very severe abdominal pain. So in the corporate hospital, they were increasing the dose of morphine. They tried fentanyl. They tried everything possible, that the patient's pain was not settling. The patient was having severe abdominal pain. But on a just 5-10 minutes on patiently talking with the patient, the team in Pallium India could identify the cause of her pain was not anything related to the pancreatic malignancy. It was just constipation. They relieved the constipation and the patient was discharged the next day pain-free. Because already she was on morphine, her constipation was not addressed properly. So don't jump into conclusions. Just because a patient is having a malignancy, don't think, if the pain is not responding to your opioids, think again and again. Are you missing something? You might be missing as simple as something like a constipation or something caused by a bad posture. Pancreatic patients, they tend to steep forwards and sit. So a musculoskeletal pain can happen from such a posture. Butt sores can develop. So don't jump into conclusions. I know a clinician who actually in the beginning of the career, whenever the patient says pains, depending on the the pain score, that clinician used to jump up the analgesic ladder. So when I asked where is the pain, the clinician used to get confused. And it's like, what is the relevance of that? We already know the patient is having this particular malignancy. It is not like that. The EMA approach, I think, will be taught to you during the management. You should give attention to the detail. What is causing the pain? Don't jump into conclusions. Okay. Then rule out any red flags and yellow flags. So what are the red flags? Actually, red flags, when it comes to non-cancer chronic pain, red flags means anything that can indicate a malignancy or infection. In cancer pain, there are some emergencies in cancer pain, palliative care, spinal cord compression, infections. So all these can be considered as red flags. Anybody here knows what are yellow flags? I told rule out to red flags and yellow flags. So anybody knows what are these yellow flags? Just again to wake you up.
Maybe the emotional aspect of the pain.
Yeah, correct. It is so some amount of anxiety, depression, all these patients will have. But yellow flags means severe anxiety, severe depression, bipolar disorder, schizophrenic patients, or with suicidal ideas. These are termed as yellow flags, and that means you have to promptly refer the patient to a psychiatrist also. We need the psychiatrist's help early in this case. And in the history taking, you should also assess the factors contributing to the total pain experience, psychological, social, spiritual. So all these should come. These are the aims of your pain assessment or the history taking. Now, the 4 things that you are going to see a patient with, cancer pain, for example, and you're going to take the history. So what are the 4 basic, the prerequisites that you should be having before you're going there and you're going to sit with the patient? One is be an active listener. So what is it meant by active listening? Active listening means make a proper eye contact with the patient, give them non-verbal, your body language. With your body language, you should make them understand that you are listening. You can nod your head, you can say and that is what is known as active listening. Make an eye contact and be an active listener. Okay, again, I think if you have a class on communication, this will be dealt in detail. What is active listening? Don't interrupt with unnecessary questions to the patient, but you can ask them if anything needs further clarification. You can ask, but don't interrupt just because you don't have time. Be patient and listen actively. Okay. Second thing is show empathy and compassion. Third thing is, again and again, all bored hearing this, believe the patient. And finally, don't give any false hopes. During the history taking, if the patient cries, it is very often they will tell you a lot of things, sometimes irrelevant for us, some things will be relevant. And don't think you are a good doctor by telling them, okay, everything is going to be all right. Don't cry, everything is going to be all right. Don't give any such false hopes. Be there for the patient, hold hands if it is possible, be there for the patient. Tell them that you will be with them, in this journey. You are not going to be alone, and we will try to make the suffering as least as possible, but don't give them false hopes by telling that everything is going to be all right. So these 4 things are the prerequisites before you go on for a history taking. And how do you take the history? I generally go with Socrates, site onset character, but this is also a very good mnemonic, PQRST. P for palliative and provocative factors, that you should ask them what aggravates your pain and what reduces your pain. The quality of pain, very, very important. Again, I knew a patient who was given morphine and scaled up morphine for her pain, which was completely a neuropathic pain in the, radicular pain in the lower limb due to a spinal meds compressing the nerve root. But she was given morphine and scaled up morphine. Irrespective of that, the patient was telling the physician that I'm not getting any benefit. I'm getting only adverse effects, constipation, sedation. But since there was no other, the modality that the physician can think of, she was being, scaled up morphine. So that is why you have to very much careful about what is the quality. Is it nociceptive, neuropathic, somatic, visceral, colicky pain, whatever is the quality of the pain. Then radiation. As I said, a low back pain that radiates to the lower limb in a cancer patient, you may have to think of spinal meds and may have to go for an MRI if indicated. So the radiation is also important, and severity and impact. What is it? You should always document the pain scores. I have seen even in my pain management team that everything else is documented, all the way it started, how it has radiated, what is the quality, but they forgot to document the VAS score. Okay, I'll be telling you how to assess the pain. So Gopal sir, earlier I remember during my training in Pallium India, that if you don't document the pain score, it is like, it's a crime that you are doing. If you're assessing the pain patient and you are not documenting the pain score, it is a big crime that you are doing. Okay, so never forget to document the pain score. And temporal factors means time. Somebody is unmuted. Can you
Sorry,
please
somebody has unmuted. Sabriya, can you mute her?
Muted, sir. Sorry for that disturbance,
Yeah.
Dr. Vineetha. You may please continue.
Yeah, no problem. So temporal factors means when the patient develops pain, is it a continuous pain or is it an intermittent pain, and what does it aggravate during night, and all these are in the temporal factors. So this is what I was talking about, the temporal factors. So you can see this patient is having a background pain. So you should, if the patient is having a continuous pain or a near continuous pain, always give round the clock analgesics. This will be taught in detail during the management, the pharmacological management, but still, this is something very basic. If the patient is having a continuous or near continuous pain, don't leave them on PRN medications or SOS medications. Please give them something for the background pain, that is for a round the clock analgesic. That should be the rule number 1. Round the clock analgesics will cover most of the background pain and some part of the breakthrough pain also. And if there is a breakthrough pain which is not covered on this, you can give PRN. You should tell them this is a PRN option, but always give the round the clock medications. Now, the last part of this presentation is the tools for assessing pain intensity. As I said, it is a big mistake if you are a pain physician and not documenting pain score. So there are two types of assessment. One is unidimensional and the other one is multidimensional. So unidimensional assessment means you are just assessing the pain severity, the quantity, which the most commonly used methods are the numeric rating scale, Fraser scale, visual analog scale, etc. So you are only assessing the severity of pain. Multidimensional means like McGill and brief pain inventory, BPI. Here you will be assessing the sensory component of pain. What is the quality of pain? Is it nociceptive, neuropathic? What is the quantity or what is the severity of pain? And also how it is affecting you emotionally, what is the affective component of pain, and how it is affecting the functionality, the quality of life. So all this comes under this multidimensional assessment. So I think this everybody knows the numerical pain rating scale. It is from 0 to 10, and you should always tell the patient why you are asking this NRS, because this has happened in Palim, India only years back. One patient, when he was very much in distress due to severe pain, and a newly joined a trainee nurse was going to him and asking him every time, what is your pain score now? Earlier it was 7, what is it now? The patient told, am I a maths teacher or something? Every time you are coming to me and asking, has it reduced by 2 divisions? Has it increased by 1 division? So the patient got very much irritated, and this has happened several times in my practice also. So always tell them why you are doing that, why you are doing this. So I am quantifying this in 0 to 10 so that I can modify my treatment accordingly. So once they know why you are taking this severity scale, then they will cooperate with you. Okay, otherwise they will get irritated every time you go. Now it is 4, earlier it was 5, like that. Okay. Then the visual analog scale means the markings are on the other side of the scale. On one side of the scale, there will be like no pain at all, and the other side is excruciating pain. And this, you just have to tell the patient to point out where is your pain. And then the corresponding point on the other side of the scale will show you in millimeters what is the patient's pain out of 100 millimeter or 10 centimeter. Where does the patient's pain out of 100 or 10? Where does the patient's pain lie? So this you can, in less literate patients, you can use this very easily. Then Fraser scale is there for toddlers, 4 to 8 years. For such children, we can go for, or sometimes in older people also, we can go for the Fraser scale. Then this I'm not going into detail. McGill pain questionnaire. This has got a short form also. The main McGill pain questionnaire, it is has been validated in around I think 50 languages, and it is a very useful tool, but very, very exhaustive. If you are using for 78 descriptors and everything, a short form of McGill is available. You can refer if you are interested in further reading. Similarly, brief pain inventory, BPI also. A short form and long form is available. Short form is just 9 questions and it will take only 5 minutes to complete. So if possible, you can take a short form BPA printout and keep in your clinic and get it filled by all the patients. So you will be very sure you're not missing on the other domains, how pain is affecting the patient's functionality and the quality of life. So with that, I complete the pain assessment also. And when we complete the pain assessment, again this question, do we in our practice actually, do we underestimate pain? How much do we underestimate pain? So these are a few studies which have shown some interesting results. So one study, the first study has shown that when the pain is moderate to severe, the oncology fellows fail to appreciate severity in 73% of cases. More than 70% of cases, they couldn't appreciate the correct severity of the pain. Another study reported that the discrepancy between patient and physician evaluation of severity is a major factor or a major barrier in providing inadequate relief. And a third study in 2018, it was published, it showed that almost at least a quarter of patients, especially those with high levels of pain, more than 7/10 pain, and female patients, the pain was underestimated, never appreciated in the correct severity. So coming to the conclusion, be an active listener whenever you are dealing with a chronic pain patient, cancer or non-cancer. Be an active listener and believe your patient. Identify the type of pain, the cause of pain, what can be the cause. Don't jump into conclusions just because a patient is having a malignancy. Identify the type of pain, cause of pain, and always document the severity of pain. Treat pain early. Don't let sensitization creep in, but sometimes that is inevitable, but always treat pain early. And remember to give round-the-clock medicines for continuous pain. And I always keep this for, this slide in all my pain classes, because not in Pallium India or palliative care setup, generally in hospitals, especially in corporate hospitals and bigger institutions, when a patient develops tachycardia or a tachypnea or a desaturation or decreased urine output, immediately, code blue, code red, not code red, code blue is, or code RRT, rapid response team, everything is activated. But if a patient is screaming in pain, telling them that I'm having a 10 out of 10 pain, this kind of a response is usually not seen. I'm not telling they should activate code blue or code RRT, but immediately they should alert, the concerned pain physician or immediately the concerned clinician. But that is usually not seen. Why? Because nobody dies due to pain. Pain is, unlike tachycardia or dyspnea or desaturation, pain will not cause death. But what we don't understand or we take into account is that many people die in pain, and even worse is that many people live in pain. So that is something you have to take home, and with the hope that all those who are listening, all the signal boards in your hospital will point towards pain relief. I thank you all for the patient listening. Thank you so much.
Thank you, Vineetha. And I think we can take a few questions before moving on to the patient story. Anybody want to ask any questions?
Excuse me. Good evening, ma'am.
Yes.
Ma'am,
Vineetha, can you answer the PowerPoint presentation?
Okay.
ma'am, the aspect of neuropathic pain and where the morphine cannot be used to treatment. Can you just explain once again, because that I didn't get correctly.
No, actually, the opioids in neuropathic pain, they don't have as much benefit as in nociceptive pain.
Okay.
Okay, so there are 3 opioids which are useful in neuropathic pain. Methadone has got efficacy, tramadol, and to some extent buprenorphine is also effective. But other opioids, they will act only partially, and you will need higher doses. So you can always, I think in the pharmacological management session, they will show you the ladder for neuropathic pain. You can, in the recent guidelines, they are step 4 or step 5. you can give a trial of opioids like morphine or fentanyl, whatever is available with you for the patient. If methadone is not available, if buprenorphine is not available, tramadol is not working, you can give trial of morphine and see if the patient is responding or not. So this is often found that morphine may not produce as much benefit in neuropathic pain as in nociceptive pain. If it is not producing any response, there's no point in titrating up morphine. Okay.
Thank you. Thank you.
Vineetha, there are two questions in chat box. One is how do you address psychiatric disorders in pain management? And
Okay.
another is connected with psychiatry. How do you address or manage mental stress and emotional pain?
Okay, so ideally, our pain team should have a psychologist support. Psychiatric support is not always possible, but ideally, you should have a clinical psychologist in your team. But before that, from my side, what I do is see all chronic pain patients, all cancer or non-cancer chronic pain patients, they will have some amount of anxiety, depression, and we can deal with that by reassuring them. Again, if we can give some mood stimulants or something, we can address that to some extent from our level. But the patient is having a more severe issue like suicidal ideas or concomitant, they are having some other psychiatric comorbidities like bipolar disorder, schizophrenia, then you should promptly refer the patient to a psychiatrist. Otherwise, from our side, for example, the patient is having a centrally sensitized pain like fibromyalgia, and I have to decide on which drug I have to give. The patient is also having severe anxiety depression. It's not severe, some amount of anxiety depression. I may prefer amitriptyline over pregabalin because amitriptyline has got some mood stimulating effect also. So, and also from my end, I will try to give the reassuring and some kind of counseling to the patient. But ideally, you should have a clinical psychologist in your team. And prompt psychiatric referral if you see there are yellow flags, that is more severe psychiatric issues. And I think that answers both questions.
There is another question. Sometimes there will be some difficulty in differentiating between nociceptive and neuropathic pain. So,
Okay.
do you have any tips?
Yes, yes. The most common tool that I use, I thought of adding this in this actually presentation, but I didn't get the correct. I mean, I didn't get time actually. That is known as Dollar Neuropathic 4, DN4. You all should take a printout of DN4 questionnaire and keep in your pain clinic. And DN4 is a very simple questionnaire. You can use, I think, 10 items are there. There is a patient having burning type of pain, painful cold, is touch causing pain, hyperalgesia, allodynia, like that 10 questions are there. And before the patient enter the clinic itself, because if you're too busy in your OPD, you can get this filled by the patient. So why it is known as DN4 is, one reason why it is known as DN4 is, if the score is more than 4 out of 10, then you can say that the patient is having a predominantly neuropathic pain. So this is what I regularly do. But there are other neuropathic, assessment tools like LAN scale, pain detect, PD scale, and so many other scales are available. But in my experience, the simplest is DN4. Please take a printout and keep that in your pain clinic and get it filled by all your patients. If it is more than 4 by 10, you can say that the pain is predominantly neuropathic. But in similar terms, it is like the burning, pricking, predominantly the patient's character of pain. They may have an aching, catching component, but predominantly the patient's pain is pricking, burning, scalding, that numbness, paresthesias, then that goes towards neuropathic pain. Anything else, sir?
Ma'am,
Yeah,
if I can ask,
somebody
sorry.
has
Sure.
Can I ask? I wanted to know any other examples are there in nociplastic apart from fibromyalgia?
Yes, nociplastic classical example is fibromyalgia, but in any pain in which there is this persistent idiopathic facial pain, PIFP. Okay, or atypical facial pain. So atypical facial pain is one example in which the patient might have undergone at least 10 dental extractions before coming to you, thinking that it is a dental pathology. Some clinicians, neurologists think that it is trigeminal neuralgia. Some think it is spinopharyngeal neuralgia. But if you look at the definition of atypical facial pain or persistent idiopathic facial pain, there is no obvious injury either to the nervous system or to the dental problem, or nothing is there. Nothing can explain why, but the patient will be having severe facial pain. Okay, severe. The differentiating factor from trigeminal neuralgia is a shock-like intermittent pain, whereas persistent idiopathic facial pain is a continuous aching pain, more of a continuous pain. But everybody will look for a cause, and I had a patient in my institute where I studied. Almost the entire front set of teeth, the upper and lower, has been removed, thinking that it is a dental cause. So another cause which I have seen and I have addressed, this is facial pain, atypical facial pain. Then this fibromyalgia is there, post-surgical, chronic post-surgical pain is there. So many examples. Any case in which you are not able to identify what an identifiable injury, but the nociception is altered, that is a nociplastic pain.
Apart from the opioids that you mentioned for neuropathic pain, what else are TCAs, tricyclic antidepressants helpful?
Yeah, I didn't go into that because that class will be there for you, pharmacological management. Anti-neuropathic agents are the mainstay. Opioids are only for, anti-neuropathic agents will not work overnight. So opioids are just to cover that time. If at all you are giving opioids, it is just to cover that time. The mainstay will be gabapentinoids, TCAs, SNRIs. That class will be there for you.
Okay. Thank you, ma'am.
I can see there are a lot more questions, but I think we have to stop now and has to go for case presentation. But Sripriya, can you save the chat questions, and maybe we can send to Vineetha and we can get it answered. Or if Vineetha gets time in between, she will also see the chat box. So I think we will move on to the patient story.
Yes,
I
sir.
think
Sharing the
today's
screen while
patient
seeing.
story will be presented by Dr. Parul Raina.
Good evening, everyone. Yeah, good evening, everyone. Thank you so much, ma'am, for the wonderful presentation. I'm currently working as an assistant professor in the Sharda Hospital. Coming to the case, my patient is a 16-year-old female patient who is actually a diagnosed case of fibromyalgia. The presenting complaints of the patient were the generalized body ache. The patient said that she even has pain to touch in all over the body, especially the shoulders and arms. She complains of depressed mood and easy fatigability. The patient is accompanied by the mother. The history is given by the patient herself. The patient gives a history of generalized body ache, which was around for 5 to 6 months, which has increased for 1 or 2 months. The patient also complained of pain on touch all over the body, especially the shoulders and arms. Pain is also present in the knee, ankle, and sometimes over the hands. It is associated with extreme tiredness and inability to focus on the studies. There is disturbed sleep due to pain, and she often wakes up unrefreshed and in pain. Though she can do her daily routine activity, she said that she was in constant pain and cannot go for the outdoor activities. Pain is especially increased in the cold weather. And when I asked her about the relieving factors, she said that hot water bags or a hot shower bath eases her pain. She said that her concentration on the studies have increased a lot. Her mood is often low, and she also feels helpless. On general examination, the patient is alert and oriented. Patient looks sad and she was quite restless. Though her vitals and system examination were not significant, there was no swelling over the joints as well. There was no skin lesions. There was a significant tenderness even while touching her, she said that there is extreme pain. And I especially noticed on the pain was more while touching on the medial aspect of the neck or on the medial aspect of the arms and over the medial aspect over the knees. The NRS score, when I asked her, she said it is almost like 6 to 7 most of the times. And in the morning, it reaches up to 9. Then I assessed her the widespread pain index and the symptom severity score, which are usually assessed for a diagnosis of fibromyalgia. Her widespread pain index was 15 and symptom severity score was 7. Next slide. This has been adapted from the American College of Rheumatology regarding how to calculate the patient's widespread pain index. Here, we usually ask the patient over the past 1 week in which body areas the patient is having pain, and you just score depending upon how many areas the patient is having pain. Next slide, please. And the second part has a 2 components: symptom severity and the levels of severity and the other somatic symptoms. Here again, we ask the patient during the past 1 week, over the past week, how much is the symptom severity, where 0 comprises no problem, 1 includes slight and mild, and 2 moderate, and 3 is severe. There is a fatigue, waking unrefreshed, and cognitive symptoms. And in other somatic symptoms, there are various other symptoms. Next slide. The other somatic symptoms are various, right from ranging from depression, easy bruisability, muscle weakness, headache, numbness, dizziness, or even tinnitus as well. And we calculate and we give the roundabout the symptoms and measure the symptom severity score. Next. The patient was already shown to multiple doctors, and all investigations were done already. Which included ESR, CRP, rheumatoid factor, anti-CCP, which were all normal, including vitamin D and vitamin B12 levels were also normal. She was on simple analgesic Myospas, which includes paracetamol plus chlorhexazone, which gave her some relief. And she was also on the multivitamins, which were already prescribed to her. The patient belongs to good socioeconomical status. Mother is actually a diagnosed case of SLE, and she herself has fibromyalgia since past 20 years. Mother is not taking on any treatment. When I asked her treatment, what is she taking for her treatment, she said that she just manages like that. And mother is actually apprehensive and concerned whether her daughter too has SLE or not, and how much physically she will be getting affected. Does her pain will lead to any physical impairment? She often convinces her daughter that she has to tolerate her pain like she has been managing. Though the child is 16-year-old, she is well aware of her condition and she tries to cope up, but still find herself in despair. I tried to start her on the medicines. I told her there are 3 medicines currently which have been FDA approved, which are duloxetine, pregabalin, or melnicapran. But her mother refused to start any medicines. She said, I know that medicines are not going to help her since it has not helped me. So she said straight away no for the medicines. I advised for cognitive behavioral treatment for her mother was little bit convincing, including from my side, I told her certain lifestyle modification, which includes relaxation techniques and simple basic exercises or go for a walk for 10 minutes. I tried to explain the condition to the patient as well as her to the mother also, like how she can cope up her pain and just simple things which eases her pain. Like if on the days where she's having extreme pain, she can comfort herself using warm bottles and hot shower baths, including the simple analgesics. Next slide. The main concern is the management of pain. Since the patient herself is a minor and she is undertaker of the mother, and mother is completely refusing for her actually any kind of giving any medicines, and how to manage the fatigue and the cognitive impairment in the patient. Also, how to convince the mother and how to educate her regarding her concerns and fear. So the case is, my case is 16-year-old teenager who is studying in 12th class, experiencing generalized body pain, fatigue, and disturbed sleep associated with impaired cognition, anxiety, and depression, with no other cause of pain found out on investigations. The main discussing points I would like to be discussed under, like how to manage her pain, how to counsel the patient as well as its mother, what are the various coping strategies that we can give her, how can we improve her quality of sleep, fatigue, even her quality of life, because she's still in her formative years, she's still studying and her pain is affecting her studies, and how to provide a supportive community to the child and to the mother as well. Thank you.
Thank you, Dr. Parul. So I think this is some of the participants who are here may not have heard about fibromyalgia, even though actually this is a very advanced patient story for this session. But considering that there are many people who will benefit, so we thought you to present the story. So if anybody has any comments before I ask Vineetha, you can have a comment on this. And if you have seen fibromyalgia, or if you have treated any patient. Anybody can unmute and speak. If you have any comments on the questions asked by Dr. Parul.
I have seen
Mother seems
patients
depressed, sir.
Hello.
Yeah.
Here mother seems depressed because of she's also a known case of SLE and fibromyalgia. She suffered for a very long time. That's why her experience is bad, and she's depressed. That's why she is reluctant to start medication for her daughter. So first we need to counsel her and make her to convince that medication helps a while. Along with medication, we need to educate her regarding other lifestyle changes like following what meditation or exercise, physical therapy, all those things.
Okay. Yeah. Thank you. Dr. Punita, you were telling something.
Sir, I have a very similar patient, but I have not successfully treated her. She is not willing to come for any like CBT or any other therapy also. She is on high dose venlafaxine now. She is having a lot of insomnia, bad quality of sleep, lot of allodynia. Almost a similar case for a 37-year-old female.
Okay. Thank you. So Vineetha, can you come in?
Yes, sir.
I think, can you give a basic idea of what is fibromyalgia? Because everybody will not be in the same level.
Basically,
and
yeah, fibromyalgia is one of the widespread pain disorders. As Dr. Parul has mentioned in her slides, WPI, widespread pain index, when you calculate, that will be more than 9. I think I remember. So, so patient will be having the widespread pain. It is not localized to in one limb or anything. There will be widespread pain. And if you ask me why that happens, why this widespread pain happens, as in the definition of nociplastic pain, it is an altered nociception. That is, the nerves carrying the pain is not functioning normally in the way it is supposed to function. The nerves, we can say in simpler words, the nerves are hypersensitive. So, okay, so a small input from the periphery, the nerves will be doubling it up and transmitting that to the brain. So this is basically a syndrome with an altered nociception. And in fibromyalgia, there will be many other associated factors. See, in any rheumatological condition, 50%, not any, in 50% of the rheumatological patients, like with rheumatoid arthritis or spondyloarthropathy, 50% of them will have fibromyalgia also. And fibromyalgia can occur without this rheumatoid pathology. It can occur on its own. And some theory say that apart from altered nociception, fibromyalgia is a state of increased inflammation also, central inflammation also. Some theories are like that, but mainly it is considered as a state of altered pain perception. And the patient will have morning stiffness. Usually in rheumatoid conditions, the stiffness will be for 1 to 2, maybe for 1 hour or 2 hours. But in fibromyalgia, a patient will have a morning stiffness for 3 to 4 hours. The pain will be typically worse in the morning, and there will be fatigability, sleep issues, appetite issues, bowel bladder issues. So all this actually accompanies the pain in fibromyalgia.
Yeah, Vineetha, you can also comment on the questions she has raised.
Okay, yes, sir. Actually, the first is how to manage pain since a mother is reluctant for medications. I also had a similar patient, mother with rheumatoid arthritis and daughter with fibromyalgia. Because the mother was having RA, the patient was evaluated with all the, connective tissue disorders, dsDNA, ANA, everything, but the patient was negative. Rheumatological workup was negative, but she was having severe fibromyalgia. And I was quite, amazed I was quite surprised when I heard that last sentence in Dr. Parul's presentation, that the mother told that I am living with it, you also have to. So this was the exact sentence told to me, my patient's mother also. See, all these years I have been living with this particular pain. Why are you not able to do that? So anyways, the first thing is how to convince a mother. Basically, one thing is that you can always tell why the medicines did not work for the mother. Mostly in fibromyalgia, as well as in many neuropathic pain conditions, these drugs like pregabalin or amitriptyline, they won't work overnight. It will take some time. But many clinicians, as well as patients, what they do is they take the medicine for 5 days. It is not working, they stop it. Sometimes a clinician only, they will prescribe pregabalin for 7 days, then change to gabapentin, then change to duloxetine. So we can tell the mother probably the medicine was not optimized or titrated properly. That is why she did not get an effect. And also in fibromyalgia, the medicine alone will not work. That we will come in the next, I think, questions. There are so many other factors. It should be a multi-pronged approach. So these might be the reasons why you didn't get benefit from the medications. You can try to convince a mother, but if she is not convinced, how I will go ahead is, I will go ahead with the other strategies, the physical therapy, psychotherapy, other coping strategies, advising her, all those things. And after 1 or 2 visits, once you gain the trust of the patient and the mother, I'm sure they will comply with your medications. That's what I feel. So if you want to add anything, please do so.
Thank you.
When we do this rheumatology workup, lot of tests have been done, and one of that turns out to be positive. Even in like ANA, there are subsections of so many tests. So if one of that turns out to be positive, and the patient is really over worried with that, and they start HCQ and they don't get adequate pain relief, should we take it seriously if among all the battery of tests, if one test comes positive, should we be treating that?
Honestly, I will discuss that with my rheumatology friend. Not that I send the patient to the rheumatologist, but I will discuss it personally with my, there are people whom you honestly trust, there are rheumatologists that you trust, not those who don't see the patient as a business. So you do have, in my circle, such people, and I call them and tell them this is the patient story and this particular test has turned out positive, and that is how I go ahead. Sometimes if they say that considering the patient's symptoms and this test has turned to be doubtful, if they tell that further workup is needed, I may encourage that, because If the patient is actually a rheumatological patient and an inflammatory arthropathy patient, whatever you do peripherally, the patient is not going to get benefited. Okay, unless you tackle it, at the root cause of the problem, the patient is not going to get benefited. So depending on my rheumatology friend's opinion, I will do that. That is how I do it.
In your experience, like with minor changes in this positive reports and all, how did the patients respond to treatment otherwise?
So minor changes, most of the time rheumatologists itself tell, these tests have got a lot of lab to lab variations also. So if done from any lab outside, sometimes these tests may be false positive or false negative, all these things happens. So what you can do is, see, there are certain symptoms, as I said, the early morning stiffness and all, and the other associated changes, what you see in a spondyloarthropathy, rheumatological condition, and fibromyalgia. Suppose a patient profile is very much towards fibromyalgia, would accept that one test is positive or something, you can go ahead with fibromyalgia treatment. And I have seen patients responding very well to the fibromyalgia treatment. Actually, if that patient comes back without responding, then I will take the rheumatology opinion.
This
sometimes.
patient had rheumatology opinion before, and HCQ was increased in dose, and finally she started having headache because of HCQ, and she stopped it by herself, or she skipped the dose. So that's like I was hesitant to stop the dose because rheumatologist has started it.
For that matter, rheumatologists, they give HCQs and DMRTs for fibromyalgia also. As I told in the class, there is one theory that there is a central inflammation in fibromyalgia. So many rheumatologists, they give, they either term it seronegative spondyloarthropathy, or sometimes they give HCQs for fibromyalgia also. So don't be hesitant to stop if it is not helping the patient.
Dr. Parul?
Yes, ma'am. Ma'am, I have one question. Even in the patients who have come for all the tests negative, can we start HCQs in those fibromyalgia patients, even though all the tests?
Yeah, that's what I was telling.
We can start.
That's what I was telling. Rheumatologists do that, but I don't do that in my practice.
Have you seen
rheumatologists, they do give.
Have you seen any improvement even on starting on HCQs?
Yes. A few patients I have seen, because I used to work with, till a month back, I used to work with a rheumatologist. So I have seen that some patients do get some improvement, but that we cannot generalize and say, comment on that. Let us look at the literature. If you look at the evidence, as you told very clearly, there are only 3 medicines approved, or 3 medicines with evidence for fibromyalgia: pregabalin, amitriptyline, and melnazepam. Okay. So others are like plus minus. If you want to try in your practice, you can try, but I don't think there is supporting evidence for that.
Okay, ma'am. Thank you.
Can I ask one question?
Sure.
Yeah.
For many inflammatory conditions, lifestyle changes, basically the sleep quality, stress management, diet, exercise, they show quite good improvement along with medications. So in fibromyalgia, does that has any significant component?
Yes, actually, that is what I think the third question is about coping strategies and how to improve her quality of sleep, fatigue, and cognitive impairment. See, definitely in fibromyalgia, it should be a multi-pronged approach. I always tell my patient, don't expect that this particular drug is going to cause a wonder overnight. Okay, we have to tell them the optimization of medications that will take time. And along with that, from the very first day onwards, ideally, in an ideal situation, the patient should be sent to a psychologist, clinical psychologist, for cognitive behavioral therapy, CBT, and especially in mindful meditation. If you look at the literature, has got some positive evidence, convincing evidence for treating chronic pain, not fibromyalgia as such, but chronic pain. There are many convincing evidence for mindful meditation. So you should, by the very first day itself, you should start the patient on this psychological modalities like CBT, meditation, distraction techniques, deep breathing, and various relaxation techniques. And that all comes under psychotherapy. Another prong is physiotherapy. So this is a very common mistake that I see. You send the patient to a physiotherapist, they will press everywhere in the body, telling that this is a trigger point, this is a trigger point, and the patient went with a VAS score of 7 out of 10 and now is back with 10 out of 10 pain. So when you send the patient to a physiotherapist, give a very clear, instruction to them. What they can do is, as Dr. Parul has mentioned, heat helps the patient. So some kind of heat therapies, like ultrasound and all can help the patient. TENS also has put some, and there is no good evidence, but some studies say. But apart from that, the patient should be subjected to graded physiotherapy. Graded physiotherapy means they will start with, very minor exercises that needs 1 or 2 muscles on the body to move. Hydrotherapy, walking in the water, because that will not take much exertion. So graded physiotherapy starting from minor exercises, and then they will slowly and gradually titrate it upwards. At the end of the day, at the end of the treatment, the muscle stretching has been shown to decrease the pain associated with fibromyalgia, because these muscles send impulses to the brain. You know about the A gamma afferents and all. So basically, if you stretch the muscle spindle will transmit the very useful response than the painful response. So it is very important you should start the patient on physiotherapy, but it should be graded physiotherapy. And instead, don't do very trigger point injection, dry needling everywhere. That will only increase the pain, at least in the initial part. Okay, so like this, physiotherapy, psychotherapy, optimizing the medications, and all this when taken together will help the patient in the long time.
Okay, so I think there will be some of the participants who have not seen patients with fibromyalgia for the benefits of those. As everybody told, it's a widespread pain, and they assess the tender points, both above and below the waist. So uh, you might have heard of myofascial trigger points, but myofascial trigger points and fibromyalgia are different things. And the most important things in the treatment is that many of the patients will come to you, and they might have seen many doctors, and there is no diagnosis. They are very much worried about what is happening. So nobody will recognize that this is there is something called fibromyalgia. So that's one problem. So you have to actually educate the patient. Yes, you are facing a problem, and this is called this thing, and it's a reality, because many patients come to us and tell us that doctors have told there is no condition such as fibromyalgia. So first of all, addressing and validating the patient's pain is the important step, and tell them that this is not something which we can treat overnight, but we will help you to cope with the pain, and will also will help to reduce the pain over a period of time. I think actually invasive interventions are not recommended for fibromyalgia, and some medications like amitriptyline, duloxetine, these are recommended, but with some evidence. And for non-pharmacological therapies also, like the CBT or guided exercise, those all have some evidences, but it has to be a multifaceted approach, not only the drug therapy, but as everybody told, there might be some medications, lifestyle modifications, and psychological therapies. So I think we will stop now because we exceeded the time, and if anybody has any more questions, you can send the questions to Sri Priya, and we will send it to Vineetha and try to get answered. So thank you, Vineetha, for being with us and for having an excellent class on introduction to pain. And thank you, Dr. Paru, for bringing up a patient story on fibromyalgia. And again, thanks to all, because each of you are very interested to have new journeys. So thank you. Thank you all.
Thank you, sir.
Thank you everyone for joining in. Thank you, Dr. Vineetha. We do know that you have had a very hectic day and
Thank
still
you.
you found out time to interact so actively with this cohort of doctors. Thank you so much. Thank you everyone for joining and making this session equally interactive. And just reminding that please do leave your feedbacks in the Google form as well. I can see the chat box overflowing with compliments to Dr. Vineetha. So please do take time to leave your feedbacks formally in the Google form as well. And with the promise that we will continue this discussion on pain with the focus on management of pain first part in the next session. This is Sripriya along with Dr. Vineetha and Dr. Sunil Kumar signing off from the Tips Eco Hub. See you in the next session. Till then, everyone take care. Bye-bye.
Bye. Bye.